epidemiology, microbiology, the predisposing factors to develop acute otitis media, how to establish diagnosis of AOM, the treatment, and lastly about the complication and referrals for AOM. Okay, sebelum kita pergi lebih jauh, okay, you can see that this is the picture about our ear. So, little bit about anatomy of our ear. The ears is divided into 3 parts. The outer ear, or we call it external ear, the middle ear, and also the inner ear. For acute otitis media, the problem lies in the middle ear. Ya, yang dekat sini. So, the middle ear ni consists of tympanic membrane ataupun eardrum, gegendang telinga. The malleolus is the all the small bones in the middle ear that transmit the sounds from outside into the inner ear to the nerve. Ini adalah saraf cochlea. Okay, so bila kita bercakap, we hear any sounds, it will travel inside the external ear, goes to the eardrum, so the vibration will touch the bones, the small bones, and transmit the sounds into the inner ear. Okay, so another part of middle ear ni adalah there's a lots of tissue here and also the eustachian tube. Ini adalah eustachian tube. Okay, so eustachian tube ni walaupun dia adalah kita kata part of the inner ear, tetapi the problem with acute otitis media usually originate from the ET tube punya problem. And this ET tube, dia bersambung dengan our upper back of the throat, dekat belakang hidung dan juga tekak kita. Okay, alright. So, basically acute otitis media is a disease of middle ear, okay, bahagian middle ear ni, and it is an acute suppurative infectious process. Dia adalah proses inflammation disebabkan infection from the ET tube punya problem. Okay, when there's an infection, there will become inflammation. The process of inflammation tu akan menyebabkan collection of fluid. Okay, yang kuning ni all the fluid inside the middle ear. Okay, there's a inflammation that cause the fluid, presence of fluid yang infected, and also bila ada infection, you punya tympanic membrane ni pun akan affected. Dia akan merah bengkak. Okay, so acute otitis media is a problem of the middle ear. Okay, little bit about epidemiology. Acute otitis media is commonly occur in children rather than in adults, especially in the young children aged around 6 months to 2 years old. And the incidence of AOM declining significantly after age of 5 years. You can see in the figure, child with less than 5 years old, the incidence to develop AOM is about 45 to 60%, whereas in adults, the incidence less than 2.5%. And this related to the anatomy development of the face. Okay. And lastly, the acute otitis media are the most common pediatric infection that need antibiotic prescription. So this topic is very relevant to us, yeah. Okay. So a little bit about microbiology. To address the treatment of the acute otitis media, we have to know what are the microbiology that cause the infection of the AOM. So, from the culture, the most common are the Streptococcus pneumoniae and also Haemophilus influenza. Okay, and these two comprising about 50 to 60% of AOM cases in pediatric population. Because I can't find any study of AOM among adult population because as I said before, this AOM is more predominantly in children punya population. Okay, apart of the bacteria punya infection, they can also have the viral pathogen, iaitu viral infection. And usually when the child presented with viral infection, they have the history of viral URTI before having all the ear infection. And the two commonest virus infection are rhinovirus and also respiratory syncytial virus. Okay. What are the predisposing factors? As I mentioned earlier, the key of the AOM is related to the eustachian tube dysfunction, the eustachian problem. So the ET dysfunction or ET obstruction, these are the two common problem. Okay. So let's see the picture about ET first, about the anatomy. Okay. Eustachian tube is a small tube that runs between your middle ear and upper throat. So this is your middle ear and this is your upper throat. Okay, upper throat ni dia memang buka, the eustachian tube ni dia memang open to the inside of the nose ni, at the back of our nose, dekat dengan our throat. Okay, the function is to provide equalization of the ear pressure and also draining of the fluid from the middle ear. So kalau ada fluid dekat middle ear, dia patut keluar daripada ET to the throat, and also dia menyebabkan kalau dia pattern, maksudnya dia terbuka, dia boleh dia akan menyebabkan the pressure from outside to the inside ni equal. Jadi patient takkan rasa macam imbalance. Patient yang ada acute otitis media boleh ada imbalance, and this usually adult lah yang akan cakap dia ada problems dengan balancing, rasa macam nak terjatuh, rasa macam tak selesa, okay, because of the balancing of the ear pressure. So apa yang menyebabkan the ET tube dysfunction or blockage? The most common causes are allergy, common cold, sinus infection, ataupun attitude changes. Contohnya patient yang pergi hiking to the macam kalau mention ni Mount Kinabalu, ataupun who's patient yang naik flight, you know, suddenly dia dapat ear block kan. And lastly, patient yang pergi diving. Okay, so this is like these are all the activities that can induce barotrauma. Kita panggil barotrauma. So as you can see, dekat children, you boleh nampak dia punya ET tube ni is like a parallel, selari. Okay, so when the patient has infect like a sinusitis, allergic rhinitis or any URTI, there's a lot of secretion inside the nose. So the secretion too can travel inside the ET tube and become stuck here. Okay, when it becomes stuck, okay, inside this, it will cause problem with the ear pressure. So dekat dalam ni will have, dekat middle ear ni akan jadi negative ear pressure. So with the negative ear pressure, with the blockage here, the ET tube tak jadi dysfunction lah. Dia punya function untuk equalizing the pressure tak bagus, and the draining of the fluid also tak boleh berlaku. So this can cause inflammation. Okay, inflammation. Inflammation ni a process, macam kalau kita tengok dekat tangan kita, kalau terluka, tergaris, dia jadi merah. That merah is inflammation. Tak semua inflammation ada infection. So, mula-mula kalau ikutkan, all the nasal secretion ni bukannya infection. Okay, dia bukan ada jangkitan kuman pun. But when it become blockage, there's a problem with the ear aeration, the ear punya pressure, it become inflammation. So when the inner ear ada inflammation, they started secrete all the fluid. So all the fluid ni tak boleh keluar from the eustachian tube, they will be collected inside the inner ear, and then dia akan jadi sangat conducive for secondary bacteria infection. Okay. But when you see the rajah in the adult punya ni, you can see the ET tube ni dia lebih condong. Okay, this happen because of the anatomical changes due to pembesaran, growing up. Okay, jadi the ET tube tu jadi lebih decline, lebih slanting. Jadi when there's a nasal secretion, kalau dia travel up masuk ke dalam pun, it can go down. Or if there's a presence of inflammation pun inside because of the different pressure, the middle ear punya fluid collection can be secreted to the ET tube. Okay. Jadi, that's why if the patient ada institute dysfunction ataupun it will cause the negative pressure in that middle ear, and combined with the lack of aeration and also accumulation of fluid, these all three factors provide a conducive environment to the development of the acute otitis media. Okay, how about ET obstruction? Okay, so again, this is the picture of the inner ear and also the ET, the eustachian tube. So obstruction can be from inside or from outside. From outside, it can be any nodes or any mass that block the eustachian tube. Contohnya, patient who has lymphoma, patient who has the nasopharyngeal carcinoma, they presented with mass inside the nasopharynx area that can cause or obstruction. Okay, dia boleh menyebabkan direct impingement to the eustachian tube. Okay, kalau dia block from the inside, contohnya case patient with the lymphoma ataupun NPC mass, they underwent oncology treatment, contohnya radiation kan, radiotherapy, then this can cause fibrosis to the eustachian tube. Jadi tube ET ni menjadi sempit dan tertutup. So these are the reasons, why patient can have acute otitis media. So come to the most important part, how to diagnose, because this is a very crucial. We have to have an acute diagnosis of AOM to avoid over-treatment with antibiotic, because the mainstay of treatment for AOM is antibiotic therapy. So what we need are comprehensive evaluation of clinical presentation plus otoscopic examination to help us in establishing the diagnosis. Okay. For the clinical manifestation, usually the patient will presented with history of URTI or exacerbation of the allergic rhinitis preceding the onset of ear problem. And they usually presented with unilateral ear problem lah. The main problem usually when they come, they will complain of otalgia or ear pain. The otalgia can be mild, moderate and severe. So I think after the previous lectures, you all knew how to assess the pain, because pain is the most important part to address in the AOM aside from the antibiotic therapy. Okay, and treat accordingly lah. Okay, so apart from otalgia, they will complain of decreased hearing. Kenapa dia kurang dengar? Dia dengar muffled sound. Bunyi tu macam perlahan je. Contohnya bunyi macam kita di dalam air. Bunyi tu muffled sound. Disebabkan there's a infection dekat middle ear tu kan, menyebabkan tympanic membrane tu tak boleh bergerak dengan bagus. Bila tympanic membrane tak boleh bergerak dengan bagus, the tulang-tulang ossicle tu with the air dalam tu, dia tak boleh transmit the sounds to the inner ear. So patient will complain muffled sound ataupun decreased hearing. And if the otitis media become very bad, it will rupture the tympanic membrane. When the tympanic membrane become ruptured, the pain usually become lesser and patient will presented with purulent ear discharge. And some of the patient might presented with high-grade fever, severe pain behind here and facial paralysis. And these three are the unusual complications that patient can present with AOM. Okay, so that is the clinical manifestation. For the otoscopic examination, okay, I hope everybody know this is the otoscopic, otoscope. The otoscope is a direct view, is a apparatus to help us to directly visualize the external ear dengan inner ear. So from the otoscopy, what are the findings that suggestive of the AOM? First is the bulging tympanic membrane. I will show you the picture later. Plus, there might be presence of complete opacification of TM, di mana TM tu akan jadi kabur sedikit ataupun opaque. And then presence of erythema or redness of the tympanic membrane. And lastly, if we have the pneumotoscopy, we can test for the mobility of the tympanic membrane. For the clinic kesihatan, usually we don't have the pneumotoscopy. Okay. However, Some of the patient might have significant amount of cerumen ataupun earwax dan obstructing the ear canal. So kalau ada banyak earwax, we cannot visualize the tympanic membranes. So what we have to do adalah we have to remove the earwax. We have to remove using the gentle curettage ataupun aspiration under direct visualization. And this procedure usually kita tak buat in klinik kesihatan because we don't have the apparatus. And remember that we cannot do the ear irrigation for those patients that most likely ada AOM because we can participate the rupture of the TM. Okay. So this is the pictures of our tympanic membrane. For the normal tympanic membrane, you can see the color is a light pinkish color. It's very translucent. There's you can see this is the bones, the small bones that transmits the sounds from outside to the inside. Okay, it's a very nice looking tympanic membrane. However, patient with acute otitis media, usually the tympanic membrane, this is the tympanic membrane, become bulging. Nampak bengkak. Okay, this one also bengkak. This bengkak. And then they become hyperemic, merah, erythema. Okay, this is very reddish, angry color. Okay, you can see a lot of vascularization. Okay, and then opaque. Kan dia kata ada opaque color. You can see this is opaque. This is opaque. Dia jadi macam putih-putih. This opaque ni because of the collection of the fluid. Okay, so these are the symptoms, the signs that you can see from the otoscopy that's suggestive of the otitis media. Okay, so with the clinical history plus the otoscopy examination, you can think, oh, this patient might have otitis media, acute otitis media. But there are few differential diagnoses that you have to entertain also. First is otitis media with effusion, OME. OME basically is a presence of middle ear fluid without infection. Some of the children yang ada very bad allergic rhinitis, they can have OME. That means with the ET yang dysfunction, they have a collection of the fluid inside the ear, but there's no infection. Their problem is only tak berapa dengar. So the kids might presented with, presented with delay of speech. Bila you call, dia tak dengar. That's all things. That's why if patient is in children who presented, young children who presented with delay in speech, ataupun mother notice tak respond to call, we have to examine their ear. Okay, that is one. Number two, OME also can be associated with recent viral infection, barotrauma, and also the other thing is the ET dysfunction. Okay, and other things as I said lah, OME is more related to ET dysfunction rather than ET obstruction. Okay, their clinical features selalunya patient presented with conductive hearing loss, on and off. Kejap, ada hari dia boleh dengar, ada hari dia tak boleh dengar. And the feeling of telinga ni rasa penuh je, sensory, the sense of aural fullness. Dia rasa telinga dia macam penuh, the feeling of fullness. Okay, and in the case of chronic otitis media, the patient can have perforated tympanic membrane also. Okay, that is one differential diagnosis. Okay, second differential diagnosis is the patient has chronic otitis media. Maybe dia tak rasa, children kan, they cannot tell us when they have the acute otitis media. I mean, they cannot tell that they have pain. And then as adult pun kita tak sure, tak perasan yang dia ada ear pain. So it's become, dia boleh jadi chronic otitis media. Untreated acute otitis media can become chronic otitis media, whereby in the chronic otitis media, they presented with chronic TM perforation with chronic with recurrent infection. Okay, and ada banyak classification of COM lah yang you all tak perlu tahu, but basically this is one of the differential diagnosis of AOM. So again, the history and also the otoscopic examination is very important for us to make the diagnosis. Okay. So now we go to the treatment of AOM, especially in children. One, quart- 1/4 of the acute otitis media cases actually attributed to a viral infection. So that's why you can see, as I said before, some of episodes of AOM ni boleh resolve spontaneously without antibiotic. Sometimes the parents mungkin tak tahu pun the child ada AOM. Okay. Number 2, okay, don't forget about adequate anesthesia. As I mentioned before kan, usually they presented with otalgia, so please address the pain. At least we should give any NSAIDs, any like a PCM pun kita boleh bagi. Kita boleh bagi sirap brufen if available, and plus minus antibiotic therapy. Here, I put it plus minus antibiotic therapy because from the guideline, actually there are 2 strategies that we can implement for management of AOM in children. First, we can give immediate treatment with antibiotic therapy. Or number 2, we can practice delayed prescription, whereby we observe the kids first, and then if the symptom become worse or fail to improve after 48 to 72 hours, only then we start the child with antibiotic therapy. So these are the recommendation from the AFP, American Family Physician punya guideline. Okay. In the child less than 6 months old, if they have acute otitis media, they should be treated immediately with antibiotic. Okay. And if it's infants less than 60 days, which is less than 2 months old, and you think that this patient ada AOM, this patient from the klinik kesihatan, we have to refer to the hospital for further evaluation to avoid any masking of invasive bacterial infection. Because less than 60, because in the neonates or early infantile area, any infection of the ear can cause a very massive ataupun very difficult complication. So usually in the clinic setting, 2 months old, less than 2 months old, we have to refer to hospital, to the ENT clinic for them to do proper assessment. Okay, for the child with the 6 months old to 2 years old, with history either unilateral or bilateral AOM, from the guideline, we should treat them immediately also with antibiotic. Okay. However, if the child with unilateral AOM with mild symptom, like a mild otalgia and presentation less than 48 hours, and if they have fever, the fever less than temperature less than 39 degree, we can adopt the practice of observe and treat if the symptom worsen. However, before you do this, you have to discuss this with the parents of caregiver. Usually, I reserve this type of management for those child with history of allergic to antibiotic. Okay, so usually the parents not keen to start any antibiotic. So if they fit with the criteria, mild symptom, mild otalgia, low temperature or fever, so we can do this. However, for those child, actually for this 6 months to 2 years old, the rate for treatment failure is very high. So if the child memang tak ada history of allergic to antibiotic, so might as well we just treat them with antibiotic as early as possible. Okay. For those child with more than 2 years old and above, if they presented with toxic appearance, persistent otalgia, temperature more than 39 in 48 hours, okay, sama ada bilateral or unilateral AOM and otorrhea, again, we just treat them with antibiotic. However, if they only have mild otalgia, we can proceed with initial observation and KIV antibiotic. So you have to educate the mother, the parents or caregiver, what are the red flag symptoms that they should monitor at home and come back for treatment, for antibiotic treatment if all the red flags appears. Okay. So what are the antibiotic in the children? With relevant to the streptococcus infection and Haemophilus influenza, the first line of treatment is amoxicillin. Okay, this is from the National Antibiotic Guideline lah, Malaysian NAG. We can give 80 to 90 milligram per kg per day in 2 divided dose. Okay, for child less than 2 years old, you should give for 10 days duration. 2 to 5 years old, you have to give for 7 days. And for more than 5 years old, you have to give for 5 days. For clinical failure, this you have to alert high risk for clinical failure for those patients, for those kids that presented with history of using amoxicillin in the last 30 days, or they has concurrent purulent conjunctivitis. Because when they have the concurrent purulent conjunctivitis, actually the diagnosis might be something else. Okay, so if they have this problem, you might give, you have to give augmentin rather than amoxicillin. Okay, so if the child has allergic towards this vaccine, penicillin allergic, then you can substitute with EES or azithromycin. Okay, for adults, basically, all those patients with acute otitis media, you have to treat them immediately with antibiotic. For non-severe OAM, you can give amoxicillin as the first line, TDS dose for 5 days. However, if the symptom not improve within 48 to 72 hours, you have to classify them as severe AOM. So those with severe AOM, the treatment should be with augmentin rather than amoxicillin. Okay, so this is busy slide we need to know. Okay. One of the complications of acute otitis media is the perforation of the tympanic membrane. When they have the perforation of the tympanic membrane, you don't have to worry because majority of the child, the tympanic membrane will heal spontaneously. Okay, and when they have the perforation of the tympanic membrane, the fluid can be drained and it will relieve the middle ear pressure, and this will relieve the pain. So this is something that good, but not that really good for the child lah. Okay. However, I cannot find any data regarding topical antibiotic for patient with acute perforated AOM. Okay, you have to educate the parents and caregivers about the precautions for perforated TM, such as no swimming, no diving, and also avoid getting water in the affected ear when bathing or showering, so they can use their ear plugs. Okay. Okay. So when we should refer the case to the hospital? When the child or the patient has recurrent acute otitis media, they have unilateral AOM more than 2 episodes within 6 months. So they have recurrent. So we have to investigate why this patient has recurrent AOM. So they need more extensive evaluation, like maybe they need CT or direct visualization of the rhinoscopy to see if there's any mass inside the nose. Or patient with persistent hearing loss following AOM. Okay, after resolve the AOM, the patient still complain of hearing impairment. And lastly, patient with chronic TM perforation. Usually the TM will heal spontaneously less than 6 weeks. If more than 6 weeks, we should refer the patient to the ENT. Okay, this is the last topics, the last chapter about the complication AOM. The first complication that we should aware is mastoiditis. Mastoiditis is the area behind the ear. So at the behind of the back of the ear, there's a bones here that we call mastoid bone. So any infection of the inner ear can cause some degree of mastoiditis, some degree of infection to the mastoid bone. Okay, but Usually mastocytitis ni, the incidence to have a severe mastocytitis is very low since the introduction of antibiotic therapy. So the mastocytitis usually can presented with spectrum of disease. It can just be a mild mastocytitis whereby the patient doesn't complain of anything. There's no pain at all, and this infection will resolve spontaneously. However, some of the patient might have suppurative mastocytitis, whereby they have the severe infection of the bone, mastod point. Usually, they were presented with high-grade fever, post-auricular pain, with local swelling and erythema. Okay, here, panas and merah. Very bad if they can, very bad. Some of them can presented with facial paralysis, vertigo, and also profound hearing loss. And this happened because the infection spread to the adjacent bones, tissue, and foci. And lastly, mastocytitis can be complicated with intracranial abscess and also lateral sinus thrombosis. So this is a red flag. If the patient who has AOM presented with mastocytitis, symptom of mastocytitis, we have to refer this patient to the hospital because they can have the intracranial abscess. This complication is labyrinthitis, which is infection of the inner ear. So the patient akan complain nausea, vomiting, vertigo, tinnitus, and hearing loss. And another are facial paralysis or hearing loss, but this is very rare lah. So all these symptoms, if patient develop with AOM, hence we have to refer the patient to the hospital for the further management. Okay, with that, thank you. Okay, any questions? Senang saja kan?
Terima kasih Dr. Sima. So, kita ada soalan dari peserta. Okay, first question. Mengapa ramai orang tua komplain OME? Diagnosis dan rawatan sama ke untuk kanak-kanak dan orang tua?
Okay, kalau OME in orang tua, okay, partly because bila when we grow older, dia punya elasticity of the tissue reduce. Kan kita tahu collagen reduce and all. So the extension tube tu pun jadi macam narrowing a little bit. And then the middle ear tu semua, all the cell lining semua jadi macam aging jugalah. So they can have it's easy for them if they have any history of allergy, any URTI, okay, all these are the predisposing factors for them to have the middle ear infection. So they have OME rather than AOM. That's mean it's only fluid in the ear but no infection. So the treatment is different. For those elderly or adults with OME, okay, first, if it's persistent or recurrent, we have to refer to ENT for further evaluation. Because elderly kan, we have to think about actually other causes than obstruct the ET, such as I said before, the lymphoma, any NPC, yeah, especially among Chinese population. This is number one. Number two, okay, what we can do adalah they can give aeration. That means they can do myringotomy. Myringotomy is the tympanic membrane tu kita macam drill little bit, put a grommet. We call it grommet. Grommet tu is to allow aeration from the outer ear to inner ear. Okay, and then lastly is just treat the underlying symptom lah. If the patient has recurrent allergic rhinitis, treat the allergic rhinitis. If they have an elderly, kita memang promote them to have the pneumococcal vaccine because pneumococcal vaccine can associated with influenza kan. So we have to reduce the risk for them to get influenza. Any influenza or flu illness, any URTI symptom can predispose for them to have the OME. Okay, any other questions?
Okay, we have next question. Bacteria ada resisten daripada banyak antibiotik yang sedang digunakan. Perlu buat culture dan sensitivity test untuk diagnose OME.
Okay, so kalau diagnose, okay, yeah, the current issue actually the antibiotic resistance. That's why it's our job, the pharmacist and also the medical officer's job to be careful when you start antibiotic among our patient. That is first. Okay, first thing that we have to do. Number two, okay, the role of culture. If they just presented with mild AOM, no need. We just still treat like usual with our first line antibiotic. However, if they start develop a complication, yes, there's a role of culture. But the culture usually we can only do if they have the ear discharge. That's mean they presented with perforated TM. Only then we will proceed with culture. Otherwise, we just treat like a normal following the national antibiotic guideline.
Thank you, Doctor. So next question. Otitis external need to be treated with antibiotics.
Okay, for the otitis external, dia punya how to say, pathogen is different. Otitis external ni, it can be usually is when you cause trauma inside your external ear. Contohnya using the earbuds. Okay, so they cause inflammation inside and can cause as ear infection. Okay, there's a two school of thoughts. For me, usually I won't give any topical antibiotic. Okay, without topical antibiotic, just give analgesia because analgesia is anti-inflammatory. Any anti-inflammatory can treat the otitis external. But if it's very bad, otitis external with high grade fever, yes, you can give any any topical antibiotic. Usually kita bagi apa? Do you all know? Apa selalu? Siapa nak jawab ni? What are the usual topical antibiotic they give for otitis external?
CMC drop.
For Laila. Sorry? CMC eardrop kan? Okay, yes. Because actually I also sometimes we give the CMC eardrop is more to treat the parents rather than the patient. Okay, so tak salah juga if you want to give the CMC eardrop boleh. But you have to make sure that, because you have to make sure otitis external ni, is it really bacteria in origin or is a fungal in origin? It depends on your otoscopic findings. So before they start, they have to think about it lah. But it's not wrong to give CMC eardrops in otitis external. Okay, any other question?
Yes, we have the last question. So if given CMC eardrop and olive oil eardrop, which to be used first?
For
CMC eardrop and olive oil eardrop. So mana satu guna dulu?
untuk apa?
No
Untuk
indication.
otitis external.
Dia tak tulis indication.
Kalau I tak bagi pun, depends on your indication. Okay, kalau you nak bagi the the olive tu, usually they give as a that is an agent to liquidify the earwax. Okay, but come on lah, this is a new era. If you give olive oil, that's mean patient has to buy the olive oil. One is olive oil, this is not cheap lah. Okay, but patient might come to us cakap, oh I dah put olive oil, because it's the information all over the internet kan. Okay, so kalau dia dah pakai, well we cannot say anything, but I hope in our profession we don't tell the patient to put olive oil lah. Okay, because we have the treatment. If your patient have impacted earwax or blockage earwax, okay, you can give our usual medication. What are the medication available in our clinic for the earwax? Siapa nak jawab ni? Apa yang doktor selalu order?
Doktor PKD
Ya?
kita memang pakai olive oil.
Pakai olive oil. Okay, that is olive oil that we give, right? Kita prepare ke Laila?
Tak, memang kita beli olive oil tu untuk medical grade punya.
Yeah, so that is different. That is olive oil that we prescribe. Okay, it's not wrong lah. I thought you cakap pasal olive oil yang dekat rumah. Okay. So, which one to give first? Okay, depends. Kalau patient presented because of the otitis ear external tu, because of impacted earwax, I will give the olive oil first. I don't give CMC. We have to treat the cause kan? The cause is the impacted earwax. So, bagi the olive oil plus analgesia lah. Don't forget the syrup PCM. Okay, I hope this answer your questions. Any other questions?
That's all. No more questions. Thank you, Dr. Sima, for talk today.
Okay, thank you. Okay, take care. Bye-bye.
Thank you.
So, untuk slot terakhir bagi sesi pagi, kita menjemput pegawai farmasi dari KK Balakong, Puan Chong Hui Wen untuk menyampaikan ceramah Management of Hemorrhoid. Dijemput Puan Chong.
Good afternoon, everybody. Is my voice clear? Is my voice clear? Can anyone please give feedback?